Okay, so we left at the barbiturates. Okay, we have discussed that the barbiturates increases the duration of these chlorine channels, and as a result, the chlorine will influx inside the cell and it will cause the hyperpolarization. Okay, we have discussed the uses. Okay, the anxiety, seizures, insomnia, induction of anesthesia. And one more area where you can use the barbiturates, if anyone remember from the GI lectures. Any liver disease?
Rotor syndrome.
Not a rotor syndrome.
Krigler-Najjar.
Yeah, the Klicker-Najjar type 2, remember?
Yeah.
In that you have a deficiency of that enzyme, and result, if you give the patient cytochrome P50 inducers, that can be an improvement in the disease, right? So barbiturates can. Okay, adverse effects, they can inhibit the respiratory system, CV system. You will have a bradypnea, you will have a bradycardia, you will have a serious depression that can lead to a drowsiness, sleeping, and all these things. It can use the it can use a dependence, it can cause a dependence, it can have some drug interaction with the cytochrome P450 because it induces the cytochrome P450, so it can cause the failure of the treatment of certain drugs like the OCPs and other drugs, right? Overdose, if happens, that can lead to inhibition of your respiratory system, CV system. Okay, you will have the drowsiness and other things, and you can only give the supportive treatment to the patient. Okay, no other antidote is available for the barbiturates. It is contraindicated in the porphyria. We have discussed why. Now you have the benzodiazepines, which are much more safer than the barbiturates. It includes a drug, the diazepam, lorazepam, trazepam, the temazepam, oxazepam, midazolam, chlordiazepoxide, and the alprazolam. Okay, you need to know which drug is short acting and which drug is long acting. For the short acting, you have this mnemonic, which is atom. Atom is very small, very short, so you can remember this atom, all the short acting drugs, and these are the alprazolam, triazolam, oxazepam, and the midazolam. All the drugs having zolam in their name. Okay, this midazolam, triazolam, right, alprazolam, and one more drug which is the oxazepam. These are the shorter acting drugs, and that's why you have to give the patient frequent doses of these drugs, right? Then you have certain drugs which are not metabolized by the liver. All the drugs are metabolized by the liver, all these benzodiazepines, except three, and these are the lot, this lorazepam, oxazepam, and the temazepam. That means all these drugs having zepam in their name, oxazepam, temazepam, and the lorazepam, they are metabolized by, they are not metabolized by the liver, right? So whenever a patient is having a liver failure, you can give these drugs to them, right? The uses includes, first is a mechanism of action. They can increase the frequency, not the duration, but the frequency of opening of the chlorine channels, and as a result, more chlorine will be influx inside the cell, and that can cause the hyperpolarization or the inhibition of the neurons. They also decreases the REM sleep, you guys know. Okay, it will increase the latency of the REM sleep, and the duration of REM sleep will be decreased, right? Let's discuss all the clinical uses. Okay, they can be used for the anxiety, and please note, only for the acute anxiety attack. Whenever the patient get the acute anxiety attack, you can give these drugs, but never for the prophylaxis because of the dependence and other factors also, right? So only for the acute anxiety, once the patient is stabilized, you will give the patient anti-anxiety drugs like the SSRIs, right? So only for the acute anxiety, you can use the benzodiazepines. For the panic disorder, whenever a patient has any acute panic attack, you can give these drugs. For the spasticity, whenever a patient having spasticity, muscle spasms, you can use these benzodiazepines. Status epilepticus, we have discussed already. Okay, lorazepam, diazepam, and midazolam are frequently used as the agents. Lorazepam has the longest acting drug, but it has a half-life of 12 hours. Okay, diazepam having a half-life of like 18 hours, I think. Okay, so midazolam is the short acting, right? You can use these drugs for the eclampsia, but the first line treatment will be what drug?
MgSO4.
Magnesium sulfate, yes. Okay, and you can use them for the detoxifications. Okay, in the alcohol withdrawal, you will have some tremors. In case of alcohol withdrawals, you have the hyperactivity of the sympathetic system. You will have sweating, tremors, anxiety, right? So in order to prevent these side effects, you can give the patient benzodiazepines for the acute alcohol withdrawal. Okay, for the night terrors, because along with the REM sleep, they can also decrease the N3 NREM sleep, right?
Yeah.
So by decreasing the N3 duration of the NREM sleep, you can use these drugs as to decrease the night terrors, sleepwalking, right? Because all these things happen in the N3 phase uh, of this sleep, right? NREM sleep, right? You can use these drugs as a general anesthetic agent because they blocks all the nerve transmissions, right? But along with anesthesia, they have some side effects like the amnesia, okay? And they can be used for the muscle relaxation also. And we have discussed that you can use them for the spasticity, that's why, okay? And they can be used for the treatment of insomnia because they cause the drowsiness and the sleeping. So they can be used as the sleep aid pills. Okay, now comes the side effects. Dependence, of course. Okay, they have just like the barbiturates, they have CNS depression. It can cause the drowsiness, sleeping, right? And that's why it is contraindicated in the old age patients. You cannot give these drugs to the old age ones, okay? And they have less respiratory, the risk of respiratory depression is very much less as compared to the barbiturates. And that's why these drugs are much more safer than the barbiturates. Even in the toxicity, patient will have a normal breathing. But in case of barbiturates, their breathing will, their respiratory system will die, right? And they will get this, this respiratory failure, okay? So that's why these benzodiazepines are much more safer than the barbiturates. Okay, and whenever you have an overdose, you have an antidote for them, and that is the flumazanil. Okay, and that is a competitive. Please note, it is a competitive antagonist. So, does it decrease the efficacy or the potency? It is a competitive antagonist. So, does it decrease the efficacy of my drug or the potency of my drug?
Efficacy.
Efficacy. Are you sure? What
No,
does this efficacy mean?
I don't remember actually.
See, the highest action to, the highest action a drug can cause, right? This is the efficacy. If I draw, sorry about that. Yeah. If I draw, if this is the maximum effect a drug can cause, so I call it the efficacy of my drug. And it would be like that. Remember this one?
Yeah.
Remember this graph, right? Whenever you have a competitive antagonist, this will shift my curve towards the right? And I will have this kind of a curve. Remember?
Yeah, yeah.
So my efficacy is totally normal. It just my Km value is increasing. And as a result, the potency of my drug is decreasing, right?
Right, yeah.
So whenever I have this competitive antagonist, I'm having a increase in the, I'm having a decrease in the potency, increase in the Km value, right? I need more drug to cause the same effect. And as a result, a decreased potency. The potency is actually this thing, right? With a minimum drug, how you can get a maximum effect, right? That is a potency of a drug, right?
Yeah.
So the potency will decrease, but the efficacy will remain same whenever I have a competitive antagonist, and that is a function of my flumazanil. Okay, that one drug. So it inhibits the receptors for the GABA, and as a result, it will block the this chloride channels. Okay, and it can precipitate the seizures because if it is a patient who is on a benzodiazepine therapy, on a chronic benzodiazepine therapy, and because these drugs are used for the treatment of seizures also, if you give the patient antagonist or you suddenly stop these drugs, okay, they can precipitate the seizures of the patient. So it could be a classical question, like it would be a patient on the benzodiazepine therapy or some kind of a drug therapy, and suddenly after stopping that drug or giving the patient antidote, they started having the seizures on the withdrawal. Okay, so it would be a patient on a drug abuse. Okay, and when the patient is admitted in the hospital, okay, they suddenly started having the seizures, and they will and then the examiner will ask you what kind of a drug it could be. Okay, just a seizure will be present, no other side effect. That means the patient is having this the benzodiazepine as a therapy. If it would be a patient who is on a drug overdose and they're having a bradycardia only and the drowsiness, nothing else, just a bradycardia and the drowsiness. Okay, you will think about the benzodiazepines because no other side effects is there in the toxicity. Okay, are we good?
Yes.
Yes.
So for the toxicity, think about the bradycardia and the drowsiness. For the for the withdrawal, think about the seizures. These things will be in the drug abuse section. You will study again. So remember that for the benzodiazepines. Then you have other non-benzodiazepine agents that can be used for the treatment of insomnia, and these are the Z drugs. Okay, the zolpidem, zaleplon, and the azopiclone. Okay, these are the Z drugs, and they can be used for the treatment of insomnia. Okay, they basically work on the same receptor as that of the benzodiazepines, but they do not have any systemic effects as like the benzodiazepines. That means you cannot use them for any anxiety, for any panic orders, spasticity, epilepsy, or any other condition. They can be used only for the insomnia. Side effect, again, just like a benzodiazepines, they can cause the ataxia, they can cause the headache, confusions, drowsiness will be there. Okay, and that's why these agents are also very much riskful if you give them in the old age. So contraindicated in the old age patients because of a risk of fall. Okay, so just remember headache, ataxia, confusion. Okay, and these are the side effects. Okay, and they have a decreased dependence risk than the benzodiazepines. Okay, very important. And yeah, that would be most of the thing you must know. Okay, so just know they can be used for the insomnia as a side effect. You can have a drowsiness, you can have ataxia, headache, confusions, right? And that would be all about the non-benzodiazepine hypnotics. Any doubt?
The bradycardia you talk,
The bradycardia due to?
the bradycardia you talked about, it was due to toxicity of benzodiazepine.
Yes, toxicity of the benzodiazepines.
So the two symptoms are bradycardia and
Bradycardia, drowsiness.
okay. Okay. Thank
In
you.
case of withdrawal, you're having the seizures.
Okay, yeah. Thank you.
And these are the most common symptom only that will be found in the benzodiazepine toxicity or the withdrawal. No other symptom are generally found. Okay, so whenever you encounter such kind of cases, think about the benzodiazepines.
Okay, thank you.
Then you need to know about the orexin. Okay, which basically causes the wakefulness. It is also known as the hypocretin. Please remember these two names. Step 1 will ask you. Okay, the orexin or the hypocretin, they will cause the wakefulness. If you guys remember the narcolepsy,
Yeah.
in case of narcolepsy, you're going to have a deficiency of this orexin or the hypocretin. Okay, so these are the agents that in your brain can cause the wakefulness, and you have a agent, a drug, the suvorexant, that can inhibit these agents, and as a result you can use them for the treatment of insomnia. Okay, as a side effect, it can cause a CNS depression, headache, abnormal sleep activities, of course. Contraindications in the narcolepsy, because in narcolepsy you're going to have a deficiency of these proteins, right? So you don't want to inhibit these proteins in narcolepsy. Okay, if you have any agent who is a cytochrome P3A4 inhibitor, you cannot use these agents because they are it can cause a toxicity of these agents. Okay, and it is not recommended in a patients with the liver disease because a liver metabolism is there. So must remember point is narcolepsy and the combination with any cytochrome P450 inhibitor, because it can cause a toxicity of these drugs. And you must know that the orexin or the hypocretin are the proteins which promote the wakefulness, right? And the suvorexant inhibit it. Then you have the melatonin, okay, which actually agonist on the melatonin receptors. And you guys know whenever you have a melatonin, you will have sleep. So in the old age specifically, in a very old age patient, you can use a melatonin as the treatment of insomnia. As a side effect, they can cause a dizziness, nausea, fatigue, and headache, but they are very kind of, you don't found that side effect generally, very rare ones. Okay, and that's why they are very good agents in the old age insomnia. Okay, they will bind to the MT1 and MT2 receptors in the suprachiasmatic nucleus. Okay, any doubt on the melatonin?
No, thank you.
Then you have the triptan drugs like the sumatriptan, which are the agonist on the serotonin receptor 5-HT1B and 5-HT1D. Okay, and as a result, they inhibit the trigeminal nerve activation. And you guys know that in the migraine, the sensitization of this trigeminal nerve is causing the headache, right?
Yeah.
You
Yes.
first have that kind of a wave. Remember the name of the wave you first have? The cortical depression wave.
Yeah. Yeah.
And that cortical depression wave will release what protein?
Substance P.
Yeah, substance P1, or most importantly, other than substance P,
Serotonin.
serotonin is a treatment of the migraine, so it won't cause the migraine, right?
Neuropeptide Y?
No. CGRP, calcitonin gene related peptide, right?
Yes.
CGRP and substance P will be released and they will sensitize your trigeminal nerve, and that will cause the headache. So as a treatment, you can use the sumatriptans, which are the 5-HT1B, 5-HT1D agonists, and they will cause the vasospasm, because in your migraine, you're going to have a vasodilation and that will cause the headache. So as a treatment, you will give the patient vasopressors that will cause a vasoconstriction and will prevent the migraine. And you can also use them for the treatment of cluster headaches. Okay, so as a side effect, they will have the coronary vasospasm that can be, and that's why it is contraindicated in the patients having a unstable type of angina, or you can say a vasospastic angina. Okay, and does anyone know the pathology behind the vasospastic angina we have discussed? CVS?
Endothelial dysfunction due to his.
Yeah, exactly. And as a result, you cannot have the activation of muscarinic receptors in the endothelium. So you will have an activation of these receptors in the smooth muscles, and that will cause a vasoconstriction, right?
Yes.
Yes.
So there are these agents, because they can cause vasospasm, they're contraindicated in the vasospastic type of angina. They can cause mild paresthesias and of course the serotonin syndrome. Okay. Any doubt on this page?
No, thank you.
No, thank you.
Then you have the drugs for the Parkinson's treatment. Okay. In case of Parkinson's, you're going to have a loss of dopaminergic neurons and an axis activity of cholinergic neurons is seen. And as a result, for the treatment, I will have to activate the dopaminergic neurons and I will have to inhibit the cholinergic neurons. Okay. So you can use either the direct agonist, you can use their or you can use the indirect agonist also. Okay, so you will have the bromocriptine, okay, as a direct agonist. You will have the levodopa, okay, and this is an analog of your the dopamine, and that will act on centrally, can be used for a treatment. Okay, you have the rasagiline, salagiline. Okay, these are the COMT, which will inhibit the metabolism of dopamine. Okay, so all these agents will be used in the Parkinson's treatment. So first, let's talk about the dopamine agonists, and they will be either the ergot or the non-ergot. The ergot one are the bromocriptine, and the non-ergot one are the pramipexole and the ropinirole. They directly activate the dopamine receptors. Okay, and the use of these non-ergot agents is mainly for the restless leg syndrome. And I told you, in case of restless leg syndrome, you first uh, have to rule out the iron deficiency anemia, right?
Yeah.
Yes.
The renal disorders, liver disorders, iron deficiency anemia, they can cause the restless leg syndrome. Okay, so for the treatment of that syndrome, you can use the pramipexole, ropinirole. Other than that, you will also have to give the patient iron supplements. Okay, and one of the major side effect of these agents that you must remember is the gambling. Whenever you encounter a patient who recently started a gambling after initiation of a new drug, think about the pramipexole and the ropinirole. Okay, so that was about the dopamine agonist. Then comes the agent that can increase the availability of the dopamine, and these are the amantadine. It is an antiviral drug that will increase the dopamine release and decrease the uptake of the dopamine. And does anyone remember any other drug that has similar action on the norepinephrine that will increase the release and decrease the uptake of norepinephrine?
Amphetamines.
Amphetamines, right? They will enter into the neurons and then into the vesicles, displace all the norepinephrine in the vesicles. Okay, and all the non-epinephrine will enter into the cytoplasm or in the axons directly, right? So it will cause the increased release and decreased absorption of the non-epinephrine, right?
Yes.
So amantadine can also cause that. It will increase the dopamine release and decreases the dopamine reuptake. Okay, it can cause the libido reticularis, okay, which is nothing but just a net-like rash. Okay, it can cause the ataxia also. Okay, then those drugs which will increase the dopamine availability, L-dopa availability. Okay, and you have two agents, the levodopa and carbidopa combination. Okay, levodopa is a prodrug of which will be converted into the dopamine. Okay, by the action of dopa decarboxylase. If you guys remember, the dopa will be converted into the dopamine by the action of dopa decarboxylase, right?
Yes.
So the same enzyme can convert the levodopa into the dopamine. Now this can happen in the periphery and also into the cytoplasm. And also into CNS. But you want all the effects on the CNS only, not in the periphery. So if you give the patient that drug, and all of the dopamine is converted into the all of the levodopa is converted into dopamine in the periphery. So you will have more side effects than the actual action of the drug, right?
Yeah.
That you will give that drug with the carbidopa, which is an inhibitor of the dopa decarboxylase, and this drug cannot cross a blood-brain barrier, and that's why it will prevent only the peripheral conversion of levodopa into the dopamine. As a result, it will decrease the peripheral side effects of my levodopa, and it will increase the potency and the efficacy of my drug in the CNS. Okay. Then other agents are the entacapone and the tolcapone, which will inhibit the COMT. Okay, and by inhibiting the COMT, these drugs will inhibit the metabolism of my dopamine. So they can be used with the conjunction with the levodopa. And what kind of an interaction you call it, the levodopa and carbidopa interaction?
Synergism.
No, it is not synergism. For the synergism, both drugs must have an activity. Not addictive. Additive, no. When one drug has no its activity, but it will increase the potency of other drug, what kind of interaction it called? No one? Potentiation. Right?
Yeah.
Yeah.
Must remember all these interactions. It is known as the potentiation when one drug has no therapeutic advantage, but when given with the other drug, okay, it will increase the activity, or you can say the therapeutic advantage of other drug, right? So this is known as the potentiation. Okay, so these agents, they will increase the dopamine availability, L-dopa availability in the brain. I must say L-dopa availability. Okay. This entacapone, this drug can also cross the blood-brain barrier. Okay, so you can inhibit the metabolism of dopamine and as well as the central dopamine metabolism. Sorry, not the entacapone, but the tolcapone. Okay, the tolcapone can cross the blood-brain barrier, and that's why it will prevent both the metabolism of my dopamine in the periphery as well as in the CNS, right? Then you have agents which will prevent the dopamine breakdown, and that again are agents which are the MAO-B inhibitors, which is a monoamine oxidase. It is a mitochondrial enzyme. That means it is found in the cell inside the neurons. Okay, so drasagelin, saligelin, okay, they will act intracellularly and inhibit the mitochondrial monoamine oxidase B, and as a result, the metabolism of my dopamine will be inhibited. Similarly, tolcapone, that can cross a blood-brain barrier. Okay, it will prevent the peripheral as well as central conversion of my the metabolism of my dopamine, and this drug act on the extracellular COMT. Okay, COMT is the extracellular enzyme, MAO-B is the intracellular enzyme. Is that okay?
Yes.
So step one will give you a picture of a neuron, and they will ask you about this drug, whether drug are acting by making an arrow, or sometimes labeling the structures with A, B, C, D. You need to identify that where these agents are working. Okay. Then you have other agents which will decrease the cholinergic activity. You will have the benztropine, trihacks. Okay, they will inhibit the all these muscarinic receptors, and as a result will be used for the treatment of Parkinson's. So it is a diagrammatic representation of all the drugs we have discussed. In the periphery, you have the levodopa, which will be converted into dopamine by the dopamine decarboxylase. You will use a carbidopa to inhibit that. You will have the COMT enzyme that will convert the levodopa into the metabolite. So you have in the periphery entacapone, tolcapone that will inhibit the COMT. Levodopa can easily cross the blood-brain barrier. It will enter into the brain, and in the brain it will be converted by the DDC into the dopamine in the neurons, and as a result it will increase the release of dopamine. Again, you have certain again this dopamine can be metabolized. Okay, so by so you will use a COMT to inhibit that, and you will use the racetylene to inhibit that. Okay, you have amantadine that will increase the release of dopamine and inhibit the reuptake of the dopamine. And you have some other agents which will directly stimulate the dopamine receptors, like the the pramipexole, ropinirole, and the bromocriptine. Bromocriptine, does anyone remember the use of this agent?
Prolactinoma.
Prolactinoma, yes. And for the pramipexole, ropinirole, they will be used for the restless leg syndrome, and other therapy is the Parkinson's. Okay. Now, with the use of these agents, the levodopa, carbidopa, what happens is the threshold value, the threshold, sorry, not threshold, but the therapeutic index of this drug is keep on decreasing. Okay. So initially, when you give this drug, you have this much therapeutic window, and as a result, you can see, and that at that point you will use the drug value will increase, the effect will increase, then the drug will metabolize, effect will decrease. But even after the metabolism, the drug levels are above the threshold limit, right? So you have a normal functioning of the patient. As the disease progresses, as the time is passing, the therapeutic window of this drug is keep on decreasing. A point reach where when you take the drug level will be become too much above the toxic levels. Okay, and when the metabolism occur, the drug level get below the therapeutic level. Okay, so whenever you take the drug, you will have the on phenomena when you get a toxicity, and whenever in between when you don't take the drug and when the metabolism of the drug happen, you will get the off phenomena when the drug is no longer functionable, as you can see, right? So this is a side effect of this therapy, the on phenomena and the off phenomena. Okay, and that happens because of a decrease in the therapeutic window of the levodopa. Okay, even if you stop the drug, doesn't matter. Okay, the therapeutic window will remain like that. Okay, so they will ask you, they will give you a patient with the Parkinsonism and the treatment of the Parkinsonism, and they will ask you when the patient is having an on and off phenomena, then what you can do to prevent that, and the answer is nothing you can do. Okay, even if you stop the drug, even if you change the drug, nothing gonna happen. Okay, once the therapeutic window is decreased, it will keep on decreasing like that. Okay, so you will tell the patient that the drug response is unpredictable. That was the answer, correct? Okay. So yeah, when the off phenomena occur, you will get a bradykinesia, you will get the rigidity. When the on phenomena occur, patient will have a improvement in the symptoms, right? And yeah, that would be about that. And why this happening? Because of the progressive nigrostriatal degeneration by the levodopa itself. Okay. So any doubt on this page?
So you're saying that the discontinuation of the drug, it will not be effective because
No.
the drug is still doing its job. It's that you are no longer able to take its effect.
Yeah, of course. When you take the drug, it actually damaging your nigrostriatal pathway. Also, along with causing all this improvement in the symptoms, at the same time it is also causing a damage to the nigrostriatal pathway, and as a result, even if you stop the drug, the damage is kind of the what you say, irreversible, right? So it won't revert back. Once the therapeutic window is decreased, it will keep on decreasing. So doesn't matter if you stop the drug or not. It just that all these responses are kind of unpredictable. Okay.
Okay. And then secondly, when we say that your levodopa carbidopa interaction is progressive, what potentially gives potentiation, it is that the carbidopa is potentiating the levodopa.
Yeah, it just the carbidopa has no effect at all, right? Without the presence of levodopa, carbidopa has no effect.
Okay, so the levodopa is doing the potentiation.
No. Carbidopa is causing the potentiation of levodopa. See, carbidopa itself has no effect, but with the levodopa, it is increasing the efficacy of my levodopa, right?
Okay. Okay.
And this interaction is known as this potentiation. Whenever one drug has no therapeutic advantage, but with other drug, they're causing the increase in the potency and the efficacy of other drug.
Okay.
That is
Thank
known as
you.
the potentiation. Yes. Any more doubt on this page?
No, thank you.
So just remember, with the use of drug, you're having a decrease in the therapeutic window, and as a result, you will get the on phenomena and off phenomena. So that was about all these drugs. Okay, the levodopa can cross the blood-brain barrier, but it is not a lipid-soluble drug. It has receptors on the blood-brain barrier for the transport of these agents. But the dopamine, it has no receptors and it is not a lipid-soluble drug, and that's why it cannot cross the blood-brain barrier. Okay, carbidopa can decrease the peripheral conversion, and as a result, the side effects on the periphery of this dopamine will be decreased. And you guys know that in the periphery, dopamine can cause the vasodilation, right?
Yeah.
So you will have a partial hypertension as a side effect if you do not use the carbidopa. If you use the carbidopa, then you have more central side effects than the peripheral side effects. And the central side effects include the nausea and the hallucinations. Okay, so even after you give the patient carbidopa along with the levodopa, you will still have the hallucinations and the nausea. If you do not give the patient the carbidopa, only the levodopa is given, then you have the partial hypertension also. Step 1 can give you the combination. They will ask you what side effects can the patient present with. So it would be a nausea, hallucination if the combination is given. If the combination is not given, then the patient will have a partial hypertension also. Okay, with the progressive use, you will have an on and off phenomena. During the on periods, your patient will have a improvement in the mobility, but on the off phenomena, you will have a impaired in the motor function. Bradykinesia will occur, rigidity will occur, right? Anxiety and agitation are the other CNS side effects. So hallucinations, anxiety, agitations, these are the common side effects you will get with the combination therapy. Then you have the MAO inhibitors. Okay, the rasagiline and salicylic, they will increase the dopamine, the availability of the dopamine, right? And they will be used for the treatment of Parkinson's. Then you have the agents for the treatment of neurodegenerative diseases like the dementias, all we have studied, right? And first is the Alzheimer's disease. You have the donepezil, rivastigmine, galantamine. We have discussed. They are increasing the acetylcholine amount in the CNS, right? By inhibiting the acetylcholinesterase, right? Then other drug is the memantine, because you guys know that the NDMA receptors are also a cause of pathology, right? You need to inhibit these receptors for the treatment of Alzheimer's. So memantine and the donepezil, rivastigmine, galantamine. These are the 4 agents you will use for the treatment of Parkinson's. Okay. Then you have the amyotrophic lateral sclerosis, and the riluzole is the treatment of that. Okay. Other treatment will be that this drug, that is anidine, that inhibits the spasticity, right? So they will decrease the neuronal glutamate the excitotoxicity. Okay, and that's why you will use them for the treatment of ALS. Okay, you need to remember that drug. Actually, it is a very complex treatment of ALS. So yeah, just know that the riluzole is a treatment if asked. Then you have the Huntington disease, and the tetrabenazine is the treatment of choice, right? It will inhibit the VM80 transporters, okay, and as a result, they will decrease the dopamine packaging and release, because the VM80 is required for the release of dopamine. If you inhibit the VM80, the vesicular monoamine transporters, and you guys know what is the function of these transporters?
Transports dopa into the vesicle.
Yeah, transport the dopa into the vesicle. Not just a dopamine, not just a dopa, but other than the norepinephrine also, right?
Yeah.
So
know.
you're actually decreasing the uptake of all the dopa into the vesicles, and as a result, the dopa cannot be converted into the dopamine. So it will decreases the release of dopamine, right? So because in case of my Huntington's, you're having a high activity of dopamine and low activity of acetylcholine, right?
Yeah.
So you're having all these symptoms, and that's why you will inhibit the dopamine. So tetrabenazine for the treatment of Huntington's disease. And you can also use this drug tetrabenazine for the Tourette syndrome. In the Tourette syndrome, again, you will have this chorea and the grunting sounds, like the other symptoms, just like my choreas. Okay, you will have all the hyperactivities in the Tourette syndrome, so you will use the tetrabenazine in that also. Okay, so any doubts so far on all these neurodegenerative agents and the Parkinson's treatment?
So the vitamin E, you were not giving as a treatment, you're giving as like an addendum to the, sorry, the vitamin E is to prevent the side effects of memantine, or is it to treat the
No,
Alzheimer's?
vitamin is, it can be used to decrease the to decrease all these symptoms of the Alzheimer's, because it will decrease the loss of neurons in case of my Alzheimer's disease. It is kind of a
Okay.
neuroprotective, you can say.
Okay, but it's not helping my adverse effects from
No,
memantine.
no.
Okay.
Then you have the anesthesias, and for that, first you know about the general principles, that whenever you give the drug, you can give it either the IV route by, or by the inhaled route, right?
Yes.
So let's say you're giving the patients by the, you're giving these agents by the IV route. Okay, from the IV route, let me draw this. From this IV route, these agents must need to enter the tissues like my brain in order to cause the symptoms, right?
Yes.
Okay, let's say when I give these drugs, first they need to saturate my blood, and once my blood is saturated with these drugs, only then these drugs can enter into my tissues.
Right.
Yes.
If my blood has more solubility of these agents, then I need more agent to cause the saturation.
Yeah.
And
Yes.
as a result, more time will need in order to cause the in order to cause the effect of the anesthesia, right? Because if I have more solubility, more drug, and more time will need, so that these drugs can enter into my tissues and can cause the effects, right?
Yes.
So
Yes.
whenever I have high solubility in the blood, okay, I will have a increase in the time, right?
Yes. Yes.
Okay, now second thing, if that drug is lipid soluble, it can easily cross the blood-brain barrier, and that means less drug will be required to cause the effects.
Yes.
And that means I can say that if I have an increased solubility in the lipids, I will have an increased potency, the potency of the agent, right?
Yes.
Yeah.
Any doubt?
No.
So the faster that you are crossing the blood-brain barrier is also so it would also mean that you're leaving just as fast, right?
Faster, sorry, repeat it again, please.
Now that we can easily cross into the blood-brain barrier, we can also
Now,
leave
because I'm
blood-
easily crossing the blood-brain barrier, I will need less drug to cause the effect, right? It's just that mean. Not the speed, but you can say because it is easily crossing, not the fasterly, but easily crossing, I will need less drug to cause the same effect,
Okay, thank you.
right? That means I'm having a high potency, because that was the potency means. Less drug, more effect, right?
Yeah.
Yeah.
And so whenever I have a high solubility in the blood, I will have a very slow induction. Okay. Whenever I have a less solubility in the blood, my blood will become easily saturated with the drug. And as a result, I will have a rapid induction, right? And the recovery will take time. Now let's talk about all these inhaled anesthetics. For the inhalation, I need the lungs, right? And after my lungs are saturated with these drugs, only then these drugs can enter into my blood, right?
Yeah.
Yes.
So I have a cylinder here, which is filled with all these gases, anesthetized gases, and they have a certain partial pressure. When the partial pressure inside this container become equal to inside my alveoli, only then this drug can enter into my blood. And that is the same thing. It means saturation, right? If the partial pressure of my gas in this chamber become equal to in this chamber, only then this chamber can transfer the gases to my blood.
Yeah.
Okay. And when my partial pressure in the blood become equal to in alveoli and in container, then only this gas can travel into the tissues.
Yes.
So all of these compartments where my gas is passing, it must be fully saturated with the gas before entering into the tissues.
Yes.
And now just give me a second. Sure. So for the anesthesia, you first have the inhaled air. It will go into the lungs. It will saturate the lungs. Then it will go into the blood. It will saturate the blood. Then it will only go into the brain, right? So four
Yes.
things will determine how the anesthesia will work. And first is the arteriovenous concentration gradient. See, you have the arteries here, okay? And you have the veins here, okay? You have a blood, you have the brain and other peripheral tissues, okay? Now, let us suppose these are the capillaries, okay? And these are all my peripheral tissues drawing all that agent from the blood. Now, if all of my agent is taken up by the peripheral tissues, can this agent enter into my brain?
No.
So let us suppose I have this, anesthesia, A concentration in my artery, okay, and the anesthesia A concentration in my vein is AV, okay. Now, if I have more extraction of this anesthesia by the peripheral tissues, then I will have a low concentration in the vein.
Yes.
So I can say if the difference between the anesthesia this concentration in the arteries and the vein is increased, if the difference is increased, then that means I will have more extraction of this agent.
Right.
That means I'm having a slower onset of the action because I need my agent to reach to the this brain.
Yes.
So more drug will be needed and more time will be needed in order to saturate all these compartments, all these tissues before it can reach to my brain. So that means a slower onset of action, right?
Yes.
So having a high concentration gradient means a slow onset of action. First thing, if you have a high blood solubility, that means more drug will be needed to saturate my blood. And as a result, I will have a slower onset of action. And that is determined by the blood gas partition coefficient. If you have a high blood gas partition coefficient, that means more gas is present in the blood. That means more solubility of my gas was. And as a result, I will have a slow onset of action. Is that okay?
Yeah.
Third thing is the lipid solubility. If you have a lipid solubility, that means my drug can easily cross the blood-brain barrier. If my drug can easily cross the blood-brain barrier, that means I'm having a high potency. That means less concentration of my drug is required to cause the anesthesia, right?
Yes.
And that means I will have a very low minimum alveolar concentration. That means I need a less concentration to cause the same effect. And that's why the potency is always inversely proportional to the minimum alveolar concentration. If I have a high potency, I will need a less concentration. If I have a less potency, I will need more concentration, right?
Yeah.
So these are all the general principles that you must remember before giving the patient any anesthesia. Any doubt?
Could you repeat the blood gas partition coefficient?
See, a high blood gas partition coefficient means you're having a more gas in the blood. That means my gas has a very high solubility in the blood, right?
Yeah. Okay.
That means more saturation. That means more time will take to saturate the blood with the gas,
Yes.
because you need the the same partial pressure in both my lungs and my blood before the gas can reach to other tissues.
Yes.
Okay. So that was all the anesthesia general principles. And you have the inhaled anesthetics, and they go by the name desflurane, halothane, amiflurane, isoflurane, sevoflurane, okay, and this methoxyflurane. All of them has the flurane in their name, or the ane you can say, halothane, right? Their mechanism is totally unknown, okay, but they will do everything you must, for the effects, you must remember that they will do everything to increase their concentration in the blood. That means first they will decrease the cardiac output and the blood pressure. So if the cardiac output is decreased, that means the blood flow is decreased. That means less drug will be going to your renal and to the liver for the excretion, right?
Yeah.
Yeah.
Yes.
Second thing, they will do the respiratory depression, because the major route for the exit of the drug is the exhalation of the drug, right?
Right.
Yes.
They will cause the respiratory depression to decrease the exhalation of the drug. They will increase the cerebral blood flow so that more drug can reach to the brain. So for all of these, for all of the effects of these drugs, you just remember that they will do everything to increase their concentration in the blood, in the brain. That means they will decrease their excretion. So that could be decreased. That could be achieved by decreasing the cardiac output, by decreasing the respiratory rate, okay, and by increasing the cerebral blood flow. And they will also decrease the GFR. They will increase this renal vascular resistance. Okay, if any other effect they have, you can just know um, by keeping this thing inside your head that they will do everything to increase their concentration, right?
Yes.
If the examiner want to trick you, if they want to give you any other option, you just simply think what option is increasing the concentration in the blood. You will choose that option. That will be the right answer. Okay. So for the adverse effect, they can cause the hepatotoxicity. They will cause the hepatomegaly, right upper quadrant pain. They will have high ALT, AST count, and ultimately the liver failure can also occur. Especially true with the halothane. They can also cause a nephrotoxicity, flank pain, and high creatinine count will be there. Renal failure will be there, especially true with the methoxyflurane. Okay. And other major side effect is the malignant hyperthermia. Okay. And this condition is true with the inhaled anesthetics and with the succinylcholine. It causes a severe muscle contraction, and as a result, they will cause the hyperthermia. Okay, especially all these patients which have a autosomal dominant mutation, okay, in the ryanodine receptor gene, okay, they have a very high susceptibility of having the malignant hyperthermia. So it will be a patient whom you give these agents, either the inhaled anesthetics or the succinylcholine, and suddenly the patient is starting having this hyperthermia, high blood pressure, okay, and so in that case, think about the malignant hyperthermia. Right, a very high temperature will be there, okay, high BP would be there, high heart rate would be there, right? So that was it. So for the treatment, you need to inhibit the ryanodine receptors, okay, and that would be the dantrolene. It is an inhibitor of my ryanodine receptors, okay. So decreases the calcium release in the endoplasmic reticulum, so in the sarcoplasmic reticulum, from the sarcoplasmic reticulum into the cytoplasm. And whenever the calcium is present, you will get the contraction, right? The duration of my contraction depend upon how much time I had the calcium in the cytoplasm, right?
Yeah.
So by decreasing the calcium release, I'm actually having a relief from the contraction. So dantrolene for the treatment of the malignant hyperthermia. Okay.
Yes.
Yes.
Any doubt on the inhaled anesthetics?
No, thank you.
Okay. Then you have the IV anesthetics. Okay. They include the thiopental. If you guys remember the barbiturate, we have discussed one barbiturate can be used for anesthesia. That was the thiopental. You have the midazolam, which is a short-acting GABA, benzodiazepine, right? You have a propofol. Again, remember the anti-epileptic agents.
Yes.
We have discussed the propofol, which potentiates a GABA. You have the ketamine, which is the NMDA receptor antagonist. All of these agents are basically activating GABA, one agent inhibiting the NMDA. Okay, they can be used for the induction of the anesthesia mainly. All of these agents. Thiopental can decreases the cerebral blood flow. It has a very high lipid solubility. Okay, we will discuss about that drug later. Don't worry. It's more actions. And please note that this drug is highly lipid soluble. That is a very important point. This drug is highly lipid soluble. Okay. Second, you have the midazolam. Okay, and you use that for the sedation for the anesthesia induction. Please note that this drug can decreases the blood pressure. It can cause the respiratory depression, a very mild one, not a severe one. It can cause the the CNS depression. Of course, that's why it is used for the anesthesia, and it can also use for the severe depression. That's why the patient can have a bradycardia and the low blood pressure. This drug can also cause the anterograde amnesia, which we have discussed. The benzodiazepines has this side effect, right? Other drug is the propofol, again useful for the rapid induction of the anesthesias. Okay, and this drug again can cause the hypotension. That's why whenever you have any accident case where the pressure, where the patient is using the blood pressure, you cannot use these agents. In that case, you need to maintain the BP of the patient, right? So you cannot use the anesthetic agents in case of any trauma patient. For the trauma patient, you must use the ketamine because it has the sympathomimetic activity. It will increases the heart rate. It will increases the cerebral blood flow. It can cause the bronchodilation and it will increase the blood pressure of the patient. So for any case where the patient is having a loss of blood, you can use the ketamine for that, right? And it will increase the cerebral blood flow. Okay, and it can also be useful for the patient's asthma that are having asthma. Okay, so for the induction of anesthesia in the patient, having asthma, you can use the ketamine again because it can cause the bronchodilation. Okay, any doubt?
No, thank you.
Now, if you guys go back to the general pharmacology, we have discussed how these highly lipid soluble agents work. They first distribute into all the tissues having a very high blood flow, and then distribute to the tissues having a low blood flow, right?
Yes.
Yes.
If I draw that compartments, you have a lesser compartment that contain all these, your kidney, your liver, your brain, that have a very high blood flow. Then you have a larger compartment that consists of all these adipose tissues, bones, and muscles, right?
Yes.
So initially, when you give the patient any IV anesthetic, okay, it has two ways to go. So this was my blood vessel. I gave that agent into the blood vessel. It will first distribute into those tissues having a very high blood flow. So it will go to the brain, okay, it will go to the kidney, okay, it will go to the liver, and similarly other agents like the heart, right? After that, soon this all of that agent will redistribute into those areas having the low blood supply, but they have a very high volume of distribution in them, like the adipose tissue, okay, like the muscles, right, like the bone. And in that case, whenever you have the redistribution, all of the drug which was present in the brain that was causing the anesthesia, now it is redistributed to the other compartment, and as a result, this will cause the effect of the anesthesia to be over, right?
Yes.
The termination of effect, right? So whenever the step one asks you, all these agents, because they're highly lipid soluble, they will have a very low excretion rate, right? They will stay in your body up to like 2 days or 3 days even. Okay.
Yeah.
Yes. Yeah.
So the effect, all these effects of the anesthesia to be over, okay, all these agents must be distributed to the other parts of the body like the muscle, bone, and adipose tissue, away from the this brain, right? And that causes the rapid termination of effect of these agents. So if the step one asks you, even though these agents are lipid soluble, why they are having this rapid termination of the effects, it is because of the redistribution. Okay.
Yeah.
Any doubt on
Yes.
that part?
No, thank you.
No.
Okay, now you have the local anesthetics. Okay, like all these cane they have in their name. They are esters and they are amides. If they have only one eye, then they are esters. If they have two eyes, that means they are amides, like the cocaine even. Okay, so that means the cocaine is a ester or a amide?
Esther.
Ester, because it has only one eye, right? While all this lidocaine, right, mavivicaine, bupivacaine, ropivacaine, they have two eyes in their name, and that's why they are amides. Okay, their mechanism is to inhibit the sodium channels, and once the sodium channels are inhibited, the depolarization will not happen and the pain transmission will be inhibited, right? And because they are sodium channel inhibitors, they can also cause the vasodilation, and that's why a side effect of these agents is the vasodilation loss of BP. Okay.
Why
Yes.
is there a fall in BP?
Because of sodium channel inhibition, you need the vasoconstriction. Okay, you need the sodium channels for that also. If you inhibit the sodium channels, you will have a vasodilation. They will cause the low BP by that.
Okay, yeah, thank
It is
you.
kind of a complex mechanism, not that much simple as it's seen. Okay. So just
Okay.
know that because of inhibition of sodium channels, they can cause the vasodilation also. Okay, they will
Okay.
relax the vascular smooth muscle. So a side effect will be the hypotension. Okay, all these agents, they are kind of because they are slightly. Just give me a second. So let's discuss for the other agent, right? So once you give these agents to the patient, okay, they have a slightly dissociated form there because they are slightly basic in nature. Okay, whenever they encounter an acidic medium, they will become ionized, right?
Yes.
Let me draw this. If this is your cell, okay, and these are the sodium channels inside the cell, okay, this is all the extracellular fluid. You give these agents into the extracellular fluid, you have these agents in it, okay. Your body has a certain pH value, right? There is a
Yes.
pH in your surrounding, okay, and they have a pK which is kind of a basic, okay, and are very close to the pK of my body, to the pH of my body. And that means in the external environment, they are both in the dissociated form, that means in the ionized form, and in the non-ionized form, right?
Right.
All that non-ionized form, it can easily cross the membrane and can enter into the cell. But the ionized form can never cross the membrane, right?
Yes.
Once all these agents enter the cell, they will encounter an acidic pH inside my cell. The pH of my cell is very much lower as compared to the extracellular fluid, and as a result, they will dissociate again, they will become ionized. And after becoming ionized, they will block the sodium channels from the inside.
Okay, yeah.
Okay.
Yes.
Now, in the scenario where I have metabolic acidosis or respiratory acidosis, that means I have a very low pH. That means a distance between my pK and the pH is increased, right?
Yes.
And I
Yes.
told you, whenever I have a low pH and a basic drug, this will accept the H plus.
Yes.
It will become ionized, and if it become ionized, this means it cannot cross the this barrier, the membrane. It cannot enter into my cell, right?
Yeah.
So as a result, whenever you have an acidosis, you need more drug to cause the same effect. Is that okay?
Yes.
So do note, let's study all these agents now. So they inhibit the sodium channels from the inside of the cell. Okay, they penetrate the membrane in the uncharged form, and then they inhibit the sodium channels by binding to the cell inside the cell in the charged form, right? They will be given with the vasoconstrictors so that it will keep the drug locally, right? Like the epinephrine. It will decrease the risk of bleeding also. It will increase the anesthesia, and it will decrease the systemic concentration of my drug. Is that okay?
Yes.
So by giving them with the vasoconstrictors, I'm increasing the duration of my anesthesia, right? In case of acidic tissues or the infective tissues, okay, because they're alkaline anesthetics, they cannot penetrate the membrane, and that's why I need more anesthetic, right?
Yes.
The order of blockade, it will be the smaller fibers first and then the larger fibers later. Myelinated fibers will blocked first, then as compared to the unmyelinated fibers. So first the small myelinated fibers will blocked, then comes the small unmyelinated fibers, then comes the large myelinated, and then the large unmyelinated fibers. This is the order of blockage. Okay.
Okay.
And you guys know, the small fibers are of pain, right? So pain and temperature, it will go first. Then comes the touch and the pressure because they are large myelinated, right?
Yes.
Yes.
So the large and the myelinated fibers, the touch and pressure, it will go in the last. Okay, unmyelinated fibers and the small fibers, they will go first, like pain and temperature. We have discussed that previously, the C fibers, right? C fibers and the A delta fibers, remember?
Yeah.
Yes.
And the A alpha fibers for the proprioception and for the motor loss, they will be touch and pressure. They will die later, right?
Yeah.
So clinical use will be, of course, the anesthesias. As a local anesthetic, you can use topical anesthetic. You can use these agents. Okay, if the patient is allergic to the estrus, you can give the patient amides. Side effects include CNS excitations. It can cause the severe toxicity, like like a bupivacaine can cause it. It can cause the hypertension as well as hypotension. Mostly, they can cause the hypotension. Okay, if you give them with this vasoconstrictors, also it can cause the hypertension. Then, like the cocaine, for example, it can cause hypertension, right?
Yes.
So cocaine can cause the hypertension. Rest all agents can cause the hypotension. Arrhythmias can happen with the cocaine. Okay, methemoglobinemia can be happen with the benzocaine. Very important. Benzocaine is a very important cause for the methemoglobinemia. Okay,
Yes.
Yes.
so just remember the hypotension is the important one, arrhythmias is the important one, and the methemoglobinemia is the important one. Okay, these three side effects you must remember. Any doubt?
No, thank you.
I
Mm,
actually,
thank you.
why are the myelinated fibers more likely for or like blocked more easily? Is it because they have like the ryanodine? Sorry, not the. They already have like the sodium channels in the nodes around the.
Yeah, exactly. They have the sodium channels in the nodes. A very high concentration is there, so it will be easier to get there, right? Sorry.
Okay.
Yeah, it will be easier to get there, right, as compared to the unmyelinated fibers, which have a diffuse. All the sodium channels are diffusely spread there, right?
Okay. And then when we're talking about cocaine, I for the rest of these drugs, I thought the drugs were effective because the either the ester or the amide drug was coming into the cell and blocking it from the inside out. But
Yes.
it works on receptors on the postsynaptic, right?
Yes.
So is cocaine having an effect inside and outside? So it's going to have hypertensive and hypotensive effects, or like
See, in
vasoconstrictive?
case of cocaine can release a norepinephrine, right?
Mhm.
If the cocaine releasing the norepinephrine, it can have a sympathetic side effects, and one of the sympathetic side effect is the hypertension, right?
Okay, so you're saying it's going to do the same anesthetic properties that my esters and my amides are doing, but it's also going to have
Yeah,
an
exactly. Cocaine has multiple effects. It can increase the norepinephrine concentration, and it can also have the anesthetic effects.
awesome. Thank you.
Okay. So, any more doubt? Any more doubt?
No, thank you.
Okay. So that was a recovery from the anesthetics. Initially, you have a high concentration in the blood. From blood, it will go to the brain. A high concentration in the brain will be there. Soon, it will be redistributed into the bone, adipose tissue, and the connective tissue. And as a result, you will have a termination of the effect within 15 to 30 minutes. While from the body, the total drug will be eliminated after 1 day or 2 days event, right? So the rapid recovery is from the redistribution. Then comes the neuromuscular blocking agents, okay, and they will be used to paralyze the muscles during the surgery so that the patient cannot move their hand while operating on the hand, right? And these agents are of two types. One is the depolarizing, and second is the non-depolarizing. The depolarizing one will cause uh, they will activate all these agents for the acetylcholine, the NM receptors, okay, and they will hyper stimulate the NM receptors, and as a result, they will desensitize the NM receptors, and this is the succinylcholine. It is an agonist on the ACE receptor that will cause the sustained depolarization, and as a result, finally, it will cause a desensitization of the receptors and will prevent the muscle contraction. It has two phases. phase 1 and phase 2. In phase 1, you have the depolarization. In the phase 2, the muscle cells are repolarized, but they are now blocked. Okay, even if you give the patient cholinesterase inhibitor, it will cause all the removal of the acetylcholine. Sorry, it will cause the increase in the concentration of acetylcholine, but these agents are already activating my receptors. So in phase 1, even if you give the patient cholinesterase inhibitor, it has no use. In the phase 2, because all these cells are now repolarized, so if you give the patient ACH, maybe this can help in reversing the symptoms or all the side effects of this drug. Okay, the muscle relaxation can be reversed. Complications, it can cause the hypercalcemia. Because of the potassium channel opening, it can cause the hyperkalemia, and it can also cause the malignant hyperthermia. Is that okay?
Why is
Could
there
you repeat
hyperkalemia?
Hyperkalemia is because of the potassium channel opening. These drugs can cause the opening of the potassium channels in the extracellular fluid, and as a result, all of the potassium will leak into the extracellular fluid, and that can lead to the life-threatening arrhythmia also, because this potassium, it can cause arrhythmias, right?
Yeah. Okay. Thank you.
Now, important thing to must remember is after the succinyl choline enter into your body, it will be metabolized by the this and you call it the pseudocholinesterase, which is found in your blood vessels. Okay, a genetic polymorphism exists in case of the pseudocholinesterase. Some patients have a high concentration, some patients have a low concentration. Those patients who have the deficiency of this enzyme, they will have an increase in the concentration and duration of the succinyl choline in the blood, and as a result, they will have a prolonged action of this agent, right?
Yeah.
So
Yes.
these patients, it will it will take time for these patients to recover from the this neuromuscular blocking agents, right? So they need all this respiratory support until the effect of the succinyl choline is gone. So it would be a patient who is given this all these relaxing agents, and now they cannot wake up from the anesthesia. They are slow from wake up from the anesthesia, right? And as a result, you will know that the patient is having a pseudocholinesterase deficiency. Okay, so you need a prolonged respiratory support. It will take for these patients, approximately 1 hour or 2 hours to wake up from the anesthesia, right? So a very prolonged duration will be there. Okay.
Okay.
While in the normal patient, it take only 10 minutes for the effect of this succinyl choline to be over. Okay, but in case of any patient who's having deficiency, it will take up to hours to wake up. All right.
Yeah.
Then you have other agents which are non-depolarizing. The function of these agents is to block the NM receptors, and as a result, the acetylcholine cannot cause the contraction. They includes all the drugs having the CUR in their name, like the atacunium, okay, the rocuronium, or this vacuronium, right? All they have is the CUR in their name, and they are the competitive antagonist at the acetylcholine. So in order to reverse, because they're competitive, if you increase the concentration of acetylcholine, you can reverse the effect of these agents. So if you give the patient cholinesterase inhibitors, they can reverse the effect of these blockade. And that means you can give the patient the neostigmine or the hydrophonium. Is that okay?
Yeah.
Yes.
Now tell me, in the patient who is having a myasthenia gravis, okay, which of the following drugs can have a increased potency on such patients?
Non-depolarizing neuromuscular drugs.
Non-depolarizing, because in case of myasthenia gravis, you already has a very few receptors, right? Over that, if you give these agents to the patient, then they will have is a very high blockade, right? So in a patient who is having a myasthenia gravis, a small concentration of these non-depolarizing drugs are required to cause the same potentiation, right? Same efficacy. Okay.
Yes.
While in case of my depolarizing ones, they need the receptors to cause the depolarization. If in case of myasthenia gravis, because they do not have any receptor, so the succinyl choline won't work, right? A treatment failure will occur in case of my myasthenia gravis patient if I give them the succinyl choline, right?
I couldn't understand what you said.
See, in for the succinyl choline to work, I need the NM these receptors, right? Acetylcholine receptors, right?
Yeah.
If in case of a myasthenia gravis, I'm having a destruction of these receptors,
Yes.
then can my succinyl choline work on these receptors?
No.
So in case of my myasthenia gravis patient, if I give them succinyl choline, I will have a treatment failure, right?
Yeah.
Or anesthesia failure, I must say. Okay.
Right.
So that was all about these agents. Any doubt, please ask.
No, thank you.
Then you have the agents for the spasticity, okay, and you call them the antispasmodic agents. First is the baclofen, that again a GABA B receptor agonist, not a GABA A but a GABA B. GABA B is found in the periphery, okay, and it is a G protein coupled receptor. GABA A is a chloride channel receptor. It is a G protein coupled, so it takes time to work. Okay, so baclofen, it will be used for the muscle spasticity, but please note that it will take time for this agent to work. Okay, so in that case, you can use the patient. You can use all these benzodiazepine agents for the spasticity treatment, right? Because they work for the channels, right?
Yeah.
And please note they act on the back. That means on the spinal cord, while my benzodiazepines are acting on the CNS. Okay. Then you have the cyclobenzaprine, okay, that act within the CNS, okay, and mainly at the brainstem can cause the loss of muscle tone. That's why it will be useful for the muscle spasticity. Okay. And then you have the dantrolene. We have discussed that already. It will inhibit the randin receptors, preventing the calcium release, used for the treatment of malignant hyperthermia. That will be happen with the anesthetics, inhaled anesthetics, and the succinyl choline. Okay. Then you have the tizanidine. Okay. And yeah, please note the neuroleptic malignant syndrome. Okay, is also this drug can be used for the neuroleptic malignant syndrome also, and it will be happen after toxicity of the antipsychotic drugs. Then you have the tizanidine, okay, and it is an alpha-2 agonist. Okay, it acts centrally and will be useful for the treatment of muscle spasticity again. Okay, so baclofen, cyclobenzaprine, dantrolene, and the tizanidine. Okay, all these agents for the spasticity. Then you have the opioid analgesics. Why analgesics? Because you use these opioids mainly for the pain relief. They act on all these opioid receptors that are the endorphins and enkephalin and the dynorphins. Mainly the action is on the mu receptors, okay, that are receptors for the endorphins. Okay, on the presynaptic neurons, they will cause the inhibition of the calcium channels, and as a result, the nerve impulses cannot be transferred to the postsynaptic neurons. In the postsynaptic neurons, they will activate the potassium channel so that the potassium efflux can happen, and that will prevent the depolarization of these neurons. Is that okay?
Could you please repeat it?
In the presynaptic neurons, that means before the synapse, it will inhibit the calcium channels, and as a result, the neurotransmitters cannot be released, right?
Yes. Yeah.
Yes.
After the synapse, it will activate the potassium channels, and whenever the potassium channels activated, it will cause the efflux of the potassium, right?
Yeah.
So as a result, I will inhibit again the nerve transmission.
Right.
So ultimately, they're decreasing the synaptic transmission. They will also inhibit the release of acetylcholine, norepinephrine, serotonin, glutamate, substance P. Okay, and that's why they have an anticholinergic effect, anti-norepinephrine effect, anti-serotonin effect, okay, glutamate effects, and the pain relief effects because of inhibition of the substance P. Okay, they can also cause the direct mast cell degranulation, and because they're causing a direct mast cell degranulation, they can cause the Redman syndrome also. BP, hypotension, and the urticaria, right?
Yeah.
Efficacy, so you have the full agonist like the morphine, heroin, meperidine, methadone, codeine, or the fentanyl. You have the partial agonist. That means in case of full agonist, they will act as an antagonist. When you do not give any drug and you give only the partial agonist, they will work as the agonist, and this is the buprenorphine. Okay. Third is the mixed agonist antagonist. At some receptors, they are working as an agonist. At some receptor, they are working at the antagonist. And these are the nalbuphine, pentazocine, butorphanol. Then you have a pure antagonist drugs, naloxone, naltrexone, and the methyl naltrexone. This methyl naltrexone, it cannot cross the blood-brain barrier. Okay, and that's why it has no CNS side effects. Okay, very important. So for the use, okay, you can be use them for the pain control because they're inhibiting the substance P. Okay, you can use them for the diarrhea. If the patient is having a diarrhea, you can use these agents because they can cause the constipation. And the drug include the loperamide and the diphenhexylate. You guys already know that, right?
Yes.
In the GIT we have discussed. Okay, in the acute pulmonary edema, you can use these drugs. For the heroin addicts, you have to give the patient full agonist, a longer acting agonist like the methadone, so that they need less doses, okay, and have a more latent period. Okay, methadone mainly you will use. Okay, sometimes a combination of the buprenorphine and the naloxone can be given because a buprenorphine without any having a full agonist, it will work as an agonist, right? A mild agonist, right?
Right.
So this will maintain the patient, and you have to give the patient naloxone to have a antagonist effect also. Side effects, they can have a nausea, vomiting, pruritus. Why? Because of the release of histamine direct. Addiction can happen, respiratory depression, constipation can happen, right? Meiosis can happen with any of the agent, but the meperidine can cause the mydriasis. Very important. Meperidine can cause the mydriasis. Rest all agent can cause the meiosis. Okay, they all have the CNS depression, drowsiness. Okay, they all have a tolerance. That means after some time, all of these effects of these agents will be lost, and you need more dose in order to cause the same effect, except for the constipation. The constipation and the meiosis will remain same. Okay, rest for the pain, for the vomiting, for the nausea, for the depression. Okay, for all the CNS effects, you need to increase the dose of the agent to cause the same effect, right? But except for the constipation and the meiosis. Okay.
Yeah.
For the toxicity, you need to give the patient naloxone. Okay. And to prevent the relapse, you need to give the patient naltrexone once the patient is detoxified. Okay. Any doubt?
Could you explain when to give naloxone and when to give naltrexone?
Whenever you encounter an acute toxicity, when the patient is having this CNS depression, low blood pressure, low breath rate, and all these things, right? Constipation, right? In that case, you will give the patient naloxone. And once the patient is stabilized, then for the chronic therapy, you can give the patient naltrexone.
Okay. Yeah.
Okay. That means after he's discharged from the hospital, then for the outpatient, you can give the patient naltrexone. Okay.
Okay. Yeah. Thank you.
Now, any doubt on any of the thing on this page?
Can you
No.
explain the effect of dantrolene? And
Dantrolene. See, actually, you're having the muscle contraction because of release of calcium from the sarcoplasmic reticulum, right?
okay,
So if you inhibit the release of calcium from the sarcoplasmic reticulum, then I will have a termination of the effect. That means a contraction.
okay,
So if I give the patient dantrolene, which is a ryanodine receptor antagonist, it will prevent the release of calcium from the sarcoplasmic reticulum. And as a result, I will have a decreased concentration of calcium in the cytoplasm,
okay.
a relief from the contraction I will get, right?
All right.
Because in case of my all this magnet hyperthermia, the main pathology is the muscle contraction. I need to inhibit that, right?
Mm-hmm.
So that's why the
Okay.
dantrolene.
Okay. Okay. Thank you.
Okay. Any more doubt?
No,
No?
thank you.
Okay, then comes the methadone toxicity. It is metabolized by the cytochrome P450. After the metabolism, okay, this drug is converted into a more toxic form. Okay, sorry, I'm sorry about that. It is not the case here. See, this drug is metabolized by the cytochrome P450. Okay, so all the agents which are inhibiting my cytochrome P450, they will cause the opioid toxicity. Okay, that is a one case. Second case is the morphine. Okay, morphine, it will be converted into a more toxic form. Okay, that has more side effects. So in a patient who is having any renal dysfunction or the liver dysfunction, especially the renal dysfunction, if the patient is having a renal dysfunction, then they cannot eliminate this agent from the blood, right, from my body.
Yes.
And
Yes.
as a result, if I give the patient morphine, even a small amount, okay, to a renal failure patient, they can have a toxicity of this morphine.
Yes.
Okay, so note that the morphine, after the metabolism, it will be converted into a more toxic form, which should be eliminated from my body as soon as possible. In case of my renal failure patient, they will have a toxicity of the morphine because of the decreased excretion of this metabolite of the morphine. But with the with this methadone, it is metabolized by the cytochrome P450. So all the inhibitors of the cytochrome P450, they can cause an increase in the concentration of methadone that can cause the opioid toxicity. Okay. Then you have the mixed agonist antagonist. You have the pentazocine and the butorphanol. They both drugs are a partial agonist in the mu receptors and a full agonist in the kappa receptors. They mostly used for the analgesia to decrease the pain, of course. Okay, moderate to severe pain. Nothing much important about these agents. Just know that they are partial agonist in the mu and a full agonist in the kappa receptors. Okay. Is that okay?
Yes.
Yeah.
So, and all the symptoms are kind of very much similar to my other agents. They will all can cause respiratory depression, right? Then the full opioid agonist and less respiratory depression than the full opioid agonist because they're partial. Of course, they have less efficacy, less effect on the immune. Okay, and if you use these agents with the full opioid receptors, that means they can cause the antagonist effect, right?
Yes.
Because they're partial agonists. So in that case, they can precipitate the withdrawal. So whenever you encounter a patient who is on a full opioid therapy, okay, you cannot give these agents as a pain control because it will cause the precipitation of the withdrawal, right? Okay.
Yeah. Yeah.
Then you have the tramadol, which is again a weak, very weak opioid agonist. It can be used for the chronic pain. The must remember thing that it can cause the serotonin syndrome. Okay, and the second most important thing to remember is it will decrease the seizure threshold. So you will easily get the seizures, right? So a side effect will be the seizures and the serotonin syndrome of this agent, the tramadol. Okay,
Yes.
you use
Yes.
this agent for the chronic pain only. Then you have the glaucoma therapy. Okay, and we have discussed all of these agents before. The beta blockers will decrease the blood flow, and as a result, the formation of the aqueous humor will be decreased. Timolol, betaxolol, cartilol, all of these agents have olol in their name, so they can be used for the beta blockers. Okay, you have the alpha agonist drug. Okay, alpha 1 and alpha 2. Alpha 1 can cause a vasoconstriction like the epinephrine, so they will decrease the aqueous humor formation. Brimonidine alpha 2 agonist can decrease in norepinephrine, and as a result, it will prevent the beta receptor activation. So as a result, it can again cause the vasoconstriction. You will have a decreased aqueous humor synthesis. These agents can cause the mydriasis. Okay, and that's why they cannot be used in the narrow angle glaucoma. Okay, blurring of the vision can be there with the brimonidine. Okay, foreign body sensation, that means itching in the eye could be there. Allergic reactions like the itching and the watering eyes could be there with the brimonidine. Ocular pruritus can also occur. That means again the same itching and the and this watering eyes will be seen with the brimonidine. Diuretics like the acetazolamide, which is a carbonic anhydrase inhibitor, it will prevent the formation of my aqueous humor. Okay, it can cause the paresthesias and the urine alkalization, and it can also cause the If you give them in a toxic amount, they can cause the diuresis and the dehydration also, right?
Yes.
And the metabolic acidosis also, because it will lose all this bicarbonate from my body, right?
Yes.
So for systemic side effects, paresthesia, urine alkalization, and the metabolic acidosis. Then comes the prostaglandins, latanoprost, bimatoprost. They will increase the uveoscleral outflow, right? And the side effects is a must remember thing. They will cause the eyelash growth. They will increase the eyelash in the eyes, right? So this is an important thing, and they will darken the color of your iris as a side effect. Then you have the muscarinic agonist agent like the pilocarpine, physostigmine, ecothiopate. Okay, and they will increase the canal of sclem outflow, right? They will clear the trapecular meshwork. They will increase the outflow by the canal of sclem, right? The trapecular outflow. Okay, they can be very useful in both the acute angle closure glaucoma as well as the open angle glaucoma, but they can cause the meiosis. Okay, and they can cause the cyclospasms also. Okay, as a side effects. Any doubt?
No, thank you.
No, thank
And we are done with the neurology completely.
Thank you.
Thank you so
Okay.
much.
Thank you so much, guys. Finally,
Thank
I
you so
didn't think
much.
it. Yeah, thank you so much.
Thank you. Thank you.